All right, so we have a pretty diverse group. This presentation is probably more geared towards our MDs and DOs and our medical students, but for the sake of time, I really want to try to focus more on just the questions from the community practitioners and physicians and nurses. So I'll run through the first part fairly quickly. I'll try to hit the epilepsy symptoms that we typically seen in children. There is a PowerPoint slides available for this, so that way you kind of have your own time to go over it. So I don't want to do this being purely a didactic lesson. It's really not. I want to try to kind of get your feedback, because a lot of time it's more useful when you have questions you can kind of pepper at us, and then we can kind of help you along with that. So let's start with the first one. The basics, what is a seizure? Some of my third year medical students will probably see some of this already, because some of them have rotated with us. But seizures basically are kind of hypersynchronous activity of electrical activity in the brain cells. Usually they're cortical neurons, and these are gray matter neurons in the brain cells. Remember, thinking back to your high school neuroanatomy, that the neurons were two types of neurons. You have gray matter and white matter. So these are kind of the gray matter, right? The main stuff. And obviously how it manifests will really depend on what part of the brain is involved. And so kind of like real estate, it's location, location, location. And so you may get motor function, sometimes sensations, alertness, perception, autonomic function, like decreased heart rate, increased heart rate, respiratory changes, these kind of things. Or sometimes it's a combination of all of the above. And about 5% of all children will experience a seizure at some point during childhood. So not big numbers, but kind of a higher number than you would expect. A lot of times for those of us that work in academia and the larger medical centers, we see more of those cases. So it's slightly skewed from what many in the general population will see per se. And obviously, what is epilepsy? Epilepsy means you've had more than two unprovoked seizure and someone that has a history of seizures. The general risk of epilepsy or seizures in our general population, if you stratify for age, risk factors, demographics, ethnicity, it's about 1 to 2%. Obviously, there are different peaks that we see. Sometimes we see it in infancy, we see it kind of peak in adolescence and childhood. Then it kind of comes back in the teenage years, and it kind of goes away, and it kind of pops back up again when people are in their 20s and 30s. And then it kind of pops back up when people are a little older in their 50s, 60s, and 70s. So you can imagine at these various peaks of life, a lot of times there are certain reasons or etiology for the reasons why they have the seizure at that point in lifetime. And as I mentioned, is the second most common neurologic disorder after stroke across all demographics and age groups. This is the old classification system that we have. This is what most of you probably know. The terms still apply, and so this is why I teach with some of my medical students. There's somewhat of a new classification system, so I'm not going to try to belabor that, because this is more of a diagnosis thing, so it isn't necessarily as practical for our community practitioners. But just there's a new classification system, so this is kind of what we have now since 2017. It's kind of slowly filtering out. Most of us in neurology or the medical field see it, but some of our general practitioners still know more of the old terms. But just as a brief summary, we'll get you guys a handout as well. But we talk about the seizure types, and this is whether it's a focal seizure, whether it's coming from one side of the brain or one particular area of the brain, versus generalized, where they kind of come all at once. So sometimes you'll see that EEGs, we'll see discharges coming from both sides of the hemisphere, and sometimes it may manifest as convulsing kind of seizures. It may manifest as absence or spacing staring kind of seizures, or a combination of all of the above. And sometimes we just don't know, because sometimes when people present to you, they just see the end of the seizure. They don't know what happened initially. And then we put that together into a higher level. We call it the epilepsy types. So we put the different seizure types, because some people have focal seizures or generalized seizures. And we have some kids that have a combination of all different types of seizures. So some of our kids that have autism, development delays, cerebral palsy, they may have different multiple seizure types. And that's what we're trying to figure out as far as what's the epilepsy type. And then we put that together to get what is the epilepsy syndrome. So some of the kids that have like Dravet syndrome or Lennox-Gastaut. So some of our community physicians may see some of these kids, and our therapists may see them as well, and the school nurses. So and that's kind of the idea behind the new classification system. So same terms, but we're trying to organize it, and then at each point along the pathway, we're trying to figure out what is the reason for their underlying seizure or epilepsy, whether it's something structural, something genetic, infectious, or metabolic, immune, or sometimes we just don't know. And over time, we can hopefully tease out what's their underlying reason for their seizures or the epilepsy, and also the other symptoms they have as well, whether there's development delays, learning issues, whatever the case may be. Okay, so as far as evaluating new seizures, a lot of this is kind of what many of our community physicians would do. It can comprise up to 2% of all visits in the emergency room, and sometimes, obviously, it can necessitate in somewhat of extensive evaluation. And particularly in the pediatric population, about 40% of children who have one seizure will have another seizure. So about half of our kids that present with a first-time seizure, many of them don't have a second seizure. They just have a one-time event. So that's not uncommon. Key points in history, many of you know this already, so I will not belabor this too much. Associated factors as well, obviously developmental history, family history is always relevant. Obviously how sick or not sick the child was when they had the first seizure, and obviously any other events, trauma, toxins, that kind of stuff. And I kind of want to focus a little bit on the history itself, because a lot of times we do kind of focus on the end of the seizure, not necessarily the different components of the seizure, because a lot of times most of us will get evaluations and consults. So parents will tell, oh, my child had a seizure. If you can, when you send a referral to us, as best you can, really try to tease out the details. It is very, very helpful for us to get some more details. Even if before we see them, they help me figure out, well, are there some testing that we can do to get the evaluation started to make it a little more expeditious for the families. Sometimes there are auras that the kids may notice. Obviously, if it's a younger child that is talking, not verbal, it's a little more challenging, but obviously an older kid, a teenager, may be able to tell the parents they sense something or they feel something. Sometimes there's behavior changes, so the parents or the kids may notice themselves. There's mood behavior changes. Usually happens right before the seizure itself. It's not typically like days before that they have it, because sometimes people have migraines, make it aura, sometimes hours, days leading up to their headache or their migraine, for example. The pre-ictal symptoms, as we call it, is just like right before the seizure, and that's what the ictal part means. Sometimes the patients witness it or they describe themselves. If there's a vocal change, if there's a cry, a gasp, slurring of words, garbled speech, it's good to know from me, particularly as an epilepsy surgical fellowship trained person. That's kind of what more my bread and butter. Is I'm concerned because if they're having speech problems or problems with the words at the beginning, that makes me a little concerned because it sounds like it's possibly coming from their dominant hemisphere, from their language centers. And for me, I'm thinking 3-4 steps down the road, if seizure medications, for example, don't help, is this someone that we can do epilepsy surgery for? So that's why it's good to know some symptoms, and it helps us localize where the seizures are coming from. And obviously motor manifestations, whether it's deviation, head turning, automatism, sometimes focal movements or generalized movements, respiratory changes. I typically see more bradypnea or decreased breathing and heart rate versus increased breathing and heart rate. That's not as typical for seizures, for example. Like I said, autonomic changes, sometimes their pupils will become dilated, sometimes drooling, pallor, incontinence, or a combination of the above. After a seizure, it's not unusual for kids to be amnestic and not remember. And obviously, if the bigger convulsing kind of seizures, you may get that. For some of the kids that have absence or petit mal, when you say absence or petit mal, it means something very specific in medical literature. So I try not to use it for most of our general public, because everyone thinks petit mal is a small seizure. So that can be a staring seizure, a brief myoclonic seizure, a drop seizure. That's not technically it for us in neurology. When you take a petit mal, we're thinking absence seizures, age 5 to 6 years of age, that have these staring spells sometimes 10, 15, 20 times a day, and they have very quick recovery, versus some of our kids that have other types of generalized seizures where they're confused, they're tired afterwards. Like I said, sleepiness, confusion can be part of it. Sometimes there's speech difficulties after they have problems speaking, or there's slurred words or comprehending. Headaches and muscle aches sometimes do happen after a long seizure as well, and that's not uncommon. Some kids that have focal seizures, for example, that have a history of a brain injury and they have a weakness on one side, but for example, they have right-sided seizures and sometimes they're weak on one side, they can get a transient weakness that typically lasts a few hours, sometimes no more than a day or so. And we call that a TOTS paresis, because sometimes when kids present with weakness on one side, or an adult, for example, you think, oh, did they have a stroke or a TIA? Because that's still the differential. We don't think about it as often in kids, but kids do get strokes and TIAs as well, in addition to adults. And obviously, nausea and vomiting, sometimes we see it after a seizure as well. So it's not uncommon per se. Physical exam, I won't belabor this. Most of you know this already, so I don't want to feel like I'm telling you something you know already. So I'll run through. So here's kind of the nuts and bolts of what I really want to try to focus on, and then really give time for our physicians and staff to kind of bring some cases or some questions about cases they've seen. So I think that's more helpful. Some common childhood epileptic symptoms that many of you will see at some point, possibly. Febrile seizures. Many of us, all of us have seen a febrile seizure at some point. And obviously, febrile seizure is a seizure that occurs in setting of fever. And keep in mind that it's not necessary that the child has a fever at the time of the seizure. So it can be towards the end of a seizure, for example. So, because some kids are perfectly fine 1 minute and the next minute the temperature kind of spikes up. And so, so that counts. It's one of the most common form of childhood seizures that we see in the Western world. Anywhere from 2 to 5% of all children will experience a febrile seizure at some point. Typical age group is 6 months to 6 years. Sometimes you see 5 months to 5 years as well. Most all our pediatricians know this. We typically see it peak between the age of 18 to 24 months of age. More often, we think probably because kids are talking, they're moving, they're more mobile, they're also in daycare, they're getting sick more often. So that's part of why we see more often around that particular age group. We do classify febrile seizures based on 2 types. The most common type is what we call the typical, the simple febrile seizures, and the less common type is the atypical or the complex febrile seizures. So I kind of changed it a little bit in the sense that typically simple febrile seizures are what most of you will see. So these are kind of generalized seizures, whether it's a generalized convulsing seizure, a generalized staring seizure, a limp seizure. There's no clear focality to it. It's typically 15 minutes or less. Yes, 15 minutes is a long time, but the criteria that we set down is like 15 minutes continuously of seizures counts as a simple febrile seizure. And then they get one within a 24-hour period, that counts as a simple febrile seizure. Anything other than that, then it becomes complex or atypical. So if they have some focality to the seizure, so it's more shaking on one side, you have a head or eye turning to a particular direction. If it's more than 15 minutes continuously, or you get more than one within a 24-hour period, that makes it a complex febrile seizure. So why does it matter? Why does it matter whether it's a simple febrile seizure or complex febrile seizure? Well, I'm going to get onto that. Family history makes a difference. A lot of times when you see a little kid that has a seizure and fever, obviously you're concerned, is it a febrile seizure? Is it like a sepsis, something else going on that you're concerned about? Because obviously a simple febrile seizure, it's a little more outpatient workup versus a kid that you're concerned has sepsis or meningitis. That requires more of an urgent evaluation, right? And so family history sometimes can be very, very helpful. Obviously, we think it's not necessarily how high the temperature gets. We think it's how quickly it changes between whatever the child's baseline temperature is and the next temperature. So it doesn't have to be a high fever like 104, 105 to provoke a seizure. It can be something as small as 101, 102. Obviously, in neurology, we always get concerned for the kids that have a low-grade fever and it provokes a seizure. It makes them a little concerned because some of these kids potentially may go on to develop epilepsy or unprovoked seizures, especially if you notice that, the temperature was like a 99.9 or 100.2, kind of a low-grade fever, which is within the realm of possibility, but it's a little unusual. And obviously, the nature of underlying illness, why they had the seizure. There are genetic studies have been shown. Just FYI, this is for my medical students and my community physicians, but these are some of the chromosomes when they've done linkage studies on families that had autosomal forms of febrile seizures. As I mentioned, pathophysiology remains unclear. As with many diseases that we see, it's probably a combination of genetic factors, multiple genes, and important environmental factors as well. So not in common neurology, but also in other medical fields as well. In the families that I showed you where they did genetic studies, those are associated with sodium potassium channels. So I asked you earlier that what we mentioned earlier as far as epilepsy, the risk of epilepsy in the general population usually runs between 1 and 2%. Well, kids with febrile seizures potentially have a higher risk of developing epilepsy down the road. And part of the workup sometimes is that, when you haven't seen a kid with febrile seizures, you're trying to figure out, well, what's the workup? Obviously, if there's some focality to the seizures, it was kind of a prolonged seizure. If there's something unusual on your exam, then that makes it a little more concerned that maybe it's not just a simple febrile seizure. So maybe it requires a little bit more of a workup. For many of our physicians, they're trying to figure out, well, does this kid need an LP or a sepsis workup, or is this more of a simple febrile seizure? I have an ear infection, I treat the ear infection, and maybe see him back in a few days and see how the kid's doing, versus do I need to send them to the emergency room, to the hospital to get a further evaluation? As far as the American Academy of Pediatrics parameters and American Academy of Neurology, Usually, if it's a baby that presents with a fever and seizure under 12 months of age, it is definitely within the realm of your higher differential to consider an LP. If they're between 12 and 18 months of age, it just depends on how the kid looks. Because sometimes, obviously, with our pediatricians, meningitis in the kids is really hard to ascertain, especially nuclear rigidity meningismus. That's hard to assess in a young kid. Maybe if the kid's a 3 or 4, I think most of the pediatricians would say they have a better sense of getting that sense from an older kid versus a much younger child. Obviously, if the kid's more than 18 months of age, it's really only indicated, just depends on what your exam tells you, basically, okay? But like I said, the bottom line is how ill does a child look? If the child looks toxic or grumpy, no one's going to fault you to do a little more of an aggressive workup on this kid that had a fever and a seizure. Imaging studies really limited value for a febrile seizure per se. You don't have to image the kid basically to do an LP. Sometimes I do get referrals from some are older ER attendings that wanted to CAT scan the kid, for example, before doing an LP because they're concerned of possibly causing herniation. But if the child's otherwise alert, fontanelle soft and full, you're probably okay. You'll need to image the kid before doing LP. If the child obviously has like a bulging fontanelle and the eyes are kind of down, then okay, that's probably reasonable if you're concerned to do some kind of imaging before you do the LP. Obviously, MRI is kind of our imaging modality of choice. For many of our folks, MRI is not necessarily available urgently or quickly, especially on the weekends. And so whatever you have available as far as CT and ER, I think that's perfectly okay. EEGs, there's really not an indication for EEGs for febrile seizures, whether it's complex or simple febrile seizures. However, I will tell you that when you send some of our families for febrile seizure evaluation and you clearly document the child's febrile seizure, many times when you come to see it in private practice, whether it's with me or other doctors, oftentimes you'll see that we do order EEG with the febrile seizures. Part of it is sometimes families are waiting sometimes a few months to see their neurologist or specialist, and the kind of expectation of some kind of evaluation. So for us, an EEG it's reassuring, non-invasive, and I think it's helpful to kind of get the parents on board basically. So that's why you may see it do more in private practice than generally what is the typical consensus guidelines by the AAP and the American Academy of Neurology. Like I said, morbidity mortality is very, very low with these kids. Once a child has a febrile seizure, I usually tell most families is the more you have, the more you have. It's kind of how it goes with many things. So if there's a family history of febrile seizures, there's a high chance that this kid may have a second or more febrile seizures. If they're fairly young when they had their first febrile seizure and the temperature was very low, for example, like I mentioned, like 100.1 or 100.3, kind of a low grade temperature. And obviously the duration of fever makes a difference. As I mentioned earlier, like why is it good to know whether the child has a simple febrile seizure or complex febrile seizure? Well, kind of what I mentioned earlier, that the risk of epilepsy for you, me, everyone else, about 1 or 2%. For those kids that have febrile seizures, that risk is a little higher. So for example, for kids that have simple febrile seizures, that risk goes up to maybe 5%, depending on which meta study. So 5%, almost 5 times the risk of the general population, but there's a 95% chance a kid will do just fine, never have epilepsy and development do well. Kids that have complex febrile seizures, that risk can go up to 10%, depending on which study you look at. So 10 times the risk of the general population, almost twice the risk of simple febrile seizures, but a 90% chance that most of these kids, even with complex febrile seizures, will do well and never have another issue again. Okay, so that's good to know because a lot of times families want to know, how is my child going to do? Are they going to have epilepsy seizures? What's their development like? And so you can kind of stratify whether it's a simple febrile seizure, complex febrile seizure. You can kind of give the numbers and data that we have. All right, so of those kids that have febrile seizures, the ones that do go on to develop epilepsy or unprovoked seizure beyond the age of 5, 6 years of age, many of them go on to develop a specific type of epilepsy that we've been termed temporal lobe epilepsy. So it's a focal epilepsy that either the left or the right temporal lobe. Our adult colleagues see this more often, and many of these folks that have a history of temporal lobe epilepsy had febrile seizures when they were younger. The other ones are some other combinations of generalized epilepsy and other focal seizures not in temporal lobe, whether it's like a frontal lobe, occipital lobe, or parietal lobe. So there is something that we see. So one of the common epilepsy symptoms that we see for kids that have a history of febrile seizures is something we call generalized epilepsy with febrile seizures plus, or GEFS plus as we call it. So these are kids that continue to have febrile seizures or seizures with fevers beyond the age of 6. At some point, they start developing afebrile seizures in addition to febrile seizures in the 6 to 8 to 9 year age group. So there's an overlap between the two. Many of these kids do stop developing seizures at some point between 10 to 12 years of age. These kids we actually do put on daily preventive seizure medications. A small cohort of these kids that don't outgrow these seizures develop very bad to control seizures. Very, very hard to treat sometimes. And that's kind of what this kind of next histogram shows. So most kids with febrile seizures kind of stop. They don't have a recurrence. Some last a little longer, but they kind of go away. These kids that have general epilepsy with febrile seizures plus go have febrile seizures beyond 6 years of age. At some point, they can overlap with afebrile seizures. And the vast majority of these kids outgrow them by the time they're 10, 12 years of age. Of the ones that don't outgrow them, they have very bad to control seizures. Sometimes can be very, very hard to treat when they're older. Benign like epilepsy, many of you will see this at some point, or benign epilepsy with central temporal spikes. That's the other terminology for it. These typically occur between the age of 5 to 15 years of age. Particularly, they occur out of sleep. By the time that many have seen them or the parents will bring you a child for a seizure, they would have had a generalized convulsion. But if you delve into the history a little more and just kind of ask them more, just ask him, the child, the parent may say that, maybe a few months ago, Johnny woke up and, the face was a little droopy, maybe on one side, and he was kind of confused. I thought maybe he had a sleep, maybe slept weird on that head or a dream, and then went back to sleep. The kid may tell you that, yeah, for the few past months or something, I've had episodes where I wake up and I have problems speaking. Sometimes they notice that they're droopy on one side of the face. It can be the right or the left, or sometimes they switch back and forth. If you get this history with a generalized convulsion out of sleep, episodes out of sleep, probably more so in the first or second part of the night where they're having just kind of a droopy face, problem speaking, you probably have your diagnosis. What we typically find is when we do the EEGs, we find these kids have like central temporal spikes. And many of these kids tend to grow this by the time early adolescence. Typically, we don't start these kids on anti-seizure medication. So the Rolandic sulcus, if you think back to your medical school class, is the central sulcus. And what lies there, real estate-wise, that's important for us is the motor strip and the sensory strip. And so what you see here, this is a sample EEG that I'm showing you. The odd numbers on the left side of the brain, the even numbers on the right side of the brain. So these first leads, so you see these things that it's like points coming together. So these are what we call spikes that we see. So you see here, this coming around the temporal lobe. So here on the left temporal side, and central. After is frontal, the C is central, and the P is parietal. So that's the acronyms that we pick basically. But basically this is left side, right side, left side, right side. This is a typical EEG montage that we use. But just to point out a few things. So temporal and central. So here you have left-sided central and temporal discharges. Every now and then you also see some independent right temporal central discharges. And so what you see when you do the EEG on the kid, you'll see these discharges pop up on the central temporal, sometimes left, sometimes right. And as you get to drowsy and sleep, you see these become much more prominent. And the reason I bring the central and temporal, because here is an example, if you think back to your neuroanatomy class, I know it was a while ago for some of us, not so much for our third years, but the motor and sensory strip in the brain is organized a certain way. And so this is just kind of a satellite view of a brain. This is kind of the temporal lobes here and part of the central area of the brain, just looking front to back. But the tongue and the face is usually in the lower part, right below the temporal lobes. And as you go up, then you get the face, then you get the hands, the trunk, and the legs. What happens with these kids is the discharges start here. They go this way and they propagate this way. So that's why you may see that sometimes when it first starts, the folks report problems speaking, problems with the weakness of the face. As it spreads this way, then they get a generalized convulsion because then it flips to the other hemisphere. It's so close by. So you think about your anatomy, it sort of makes sense why these kids would have this kind of seizure propagation the way that we just described. Benign occipital epilepsy, kind of similar, but in a different part of the brain, in the occipital lobe. A lot of these kids, what happens sometimes is maybe they'll have these episodes where they have responsive, but it's kind of slow to respond. They seem out of it, but they're awake. They're not out of it completely. They kind of stare off sometimes. Sometimes they vomit, and then they headache at the end of a vomiting. Sometimes this can be confused with migraines because sometimes migraines kids do get like staring, sometimes they get vomiting headache, but it's a little different with migraine. Typically you get the headache, you get the vomiting, and then you feel better. These kids, it's kind of the opposite. They get the vomiting and then they get headache at the end of the vomiting. But obviously there's some degree of some changes to the level of alertness around prior to their episode. With these kids, what you would typically do is when we do EEGs, we'll see these kids have characteristic occipital spikes. These kids actually respond well to medications. Topamax is a medication we use for migraines. Also works for this as well. So one medication that kind of can take care of both conditions. And vast majority of folks do outgrow their epilepsy and seizure by the time they're adolescents. So most of these kids actually do pretty well. And this example of the EEG pattern for these kids that have benign occipital epilepsy. So here is O1 is occipital and O2 is right. So this is left occipital area. This is the right occipital area. So this is in between the seizure. What we see these kids have, they have these kind of this sparks happening in the occipital lobes with occipital epilepsy. Okay, childhood and juvenile absence epilepsy. So vast majority of folks will see that at some point. I know all the nurses and school administrators have seen these folks at some point. And so these are classically kids that have staring spells. So sometimes they get evaluation for, does the kid have like ADHD or ADD? They kind of zone out multiple times a day. It's, the kids are perfectly fine. All of a sudden, it's just like a sudden stop. It's as if someone unplugged the TV and they just kind of stop what they're doing. Maybe 5, 10, 15, 20 seconds later, they kind of resume what they're doing and they just aren't aware of what happened. The EEG characteristically, you see a 3 hertz spike in wave discharges. And so I'll show you an example of EEG. So a good clinical thing that you guys can do, if you suspect a kid has maybe more of an absence staring seizure, so typical age, like I said, it's typically between the age of 5, 6 years of age. So first starting school, kindergarten, first grade, teachers notice it, parents notice it, and they kind of come to you for an evaluation. If you suspect the child maybe is at the right age group, sounds like this could be more of absence seizures versus ADD, ADHD. There's something quick that you can do in your office. Most of you don't carry pinwheels in your office. We do because I'm a neurologist, but something you can do is, what I usually do is I'll tear off a strip of tissue paper and hold it in front of the kids. I'm asking the kids to blow in the tissue paper and don't let the paper go down. So basically what you're trying to do is have the kids hyperventilate. Seriously do for 2-3 minutes. The kid's going to be blue, they're going to turn pale, but really encourage them to go for 2-3 minutes. If the kid has absence seizure, there's a good chance you probably provoke an absence seizure. So they'll be hyperventilating, blow for a good 2-3 minutes. And if you provoke a seizure, what you see is you provoke an absence seizure. The kids will kind of stop all of a sudden what they're doing and they'll zone out and they'll respond to you again. Try to do it again to see if you can reproduce an absence attack by having hyperventilate again. If you captured it, you have your diagnosis basically. Obviously, I would still send to neurology so we can do the EEG to confirm the diagnosis and talk about medications, okay? But here's an example of a kid that was hyperventilating. He stops, and then you see these discharges pop up. So it's a 3 hertz spike and wave discharge that you see, but it's kind of throughout all the EEG leads. Pretty classic for benign epilepsy. Childhood absence epilepsy. As I mentioned, the most common one is what most of us will see typically between the age of 5, 10 years of age, typically more close to 5 and 6 when they first start school. The vast majority of these kids, probably 95% will outgrow the seizures by the time they're in early adolescence. There's an older version, a later onset version, I would say, in juvenile absence. So these are kids around close to 10, 11, 12 that have them. Typically at puberty, the issue with these kids oftentimes is well-controlled medication, but sometimes they don't tend to outgrow the seizures. The number one answer, usually the most common medication we use for these folks are ethosuximide, Zerontin, and Depakote. Lamictal has also been used as well. And this is the EEG pattern for absence epilepsy. Juvenile myoclonic epilepsy. So I'm almost wrapping up with the last one. So these are typically kids that present between 10 to 15 years of age, obviously. Juvenile age, it's a mixture of different seizure types. By the time the parents have brought you to evaluation to the primary care doctors or sometimes to neurologists, they would have had a generalized convulsion. But if you can try to dig into the history a little bit and just ask them, did you notice if like maybe in the past few weeks, few months, are you having kind of like these jerks? So what I'll ask the kids is, do you notice that if, Susie or Jose in the morning, do you notice that they tend to be very clumsy? Like they'll drop their toothbrush, they'll drop their cereal bowl. They tend to be a little kind of tremulous in the morning. And after an hour or two, it kind of goes away. And then you also ask them a little further, were there any issues with like learning issues, any problems with like ADD, focus attention issue when they were younger, in the kindergarten stuff? the parents may say, well, they had a history of like what we thought was ADD. They kind of had the spacing out spells, but it wasn't very often. It wasn't like multiple times a day, and they kind of went away. So if you get this history of someone that had a generalized convulsion, maybe what you're describing now are what we call morning myoclonus, these little jerks they get in the morning that goes after an hour or two. And then maybe history of like what we call atypical staring spells or atypical F-son seizures. In this age group, you probably have your diagnosis. In a kid that otherwise neurodevelopmentally and has a normal exam. And when we do the EEGs on this kid, we see a slightly higher frequency of generalized discharges. And that's what this chart shows. So you see it's a little higher frequency, but they're generalized spike and wave discharges. And sometimes they take a polyspike format. And that's kind of what this, it's like a spike, and then you get a wave, okay? So just FYI, nothing, it's just more for my medical students, I think. If there is one epilepsy to have in your lifetime, this is probably the one I would say to have, just because the vast majority of these kids or adults also will do well on just one seizure medication. They live life normal like the rest of us. They go to school, they drive, but they just have to be medication. So the flip side of that is that many of these folks tend to not outgrow the seizure. They tend to have lifelong. So that's the other flip side of being something that's well-controlled medication, but then you kind of have to be medication for pretty much the rest of your life. And valproic acid is, we use a typical medication for this one. Lamictal and Keppra have also been used as well. Okay. All right, so let me have any questions that you guys have.
There was a question a little earlier on. I kind of got dropped off the call. Sneha, did you address the question that's in the chat box?
No.
Let me see.
Okay. So there's a question here. Are auras usually visual or can they be olfactory? And there were two comments. Art said both and Jed agreed.
Yeah, so it can be a combination of different things. Yeah, so we always think of auras, but like I said, it depends on where in the brain it's starting. So sometimes if it's in the back of the head, the occipital area, as we term it's your vision centers, you may get visual auras. It almost sounds like migraine because where they're seeing scintillation, they're seeing like zigzag lines and stuff. But obviously, you'll get some other symptoms with it, like you get like altered sensorium, they're confused, they're tired, then sometimes progresses to last longer, and then you don't get the headaches per se. So yeah, so sometimes it can be a little tricky. Sometimes it may be, if it's in the temporal lobe, or hearing center, some people have heard like hallucinations sometimes. But there's other symptoms with it as well. So I don't want you to think that every single time someone has like a visual or an auditory visual hallucination that is necessarily a seizure per se. But it depends on where. Sometimes for me, it's more like they feel it's off. Sometimes it's more sensory symptoms. So they'll get like numbness and tingling, especially if the kids have like a tumor or a particular lesion that's around the motor and sensory strip. Then they'll have these symptoms in the hands and things like. And then obviously, if it progresses, then you get the typical convulsion or altered sensorium that you get with a seizure.
Excellent. Thanks for addressing that question. Yeah, we've got lots of time left, about 16 minutes here. So if you have any questions, please feel free to unmute yourselves with the mute icon on the Zoom toolbar, or you can also hit Alt-A on your keyboard, as well as write in through that chat box.
I have another question in regards to the auras. In my experience, I've seen a lot of anxiety behaviors, but that's in like the older population. Is that commonly seen with children as well, or not so much?
It really depends, So I would say that the anxiety stuff, sometimes I typically see it more in our kids who are developmentally delayed, because a lot of times they're not able to express to you what they're feeling and saying. So sometimes it may manifest as anxiety, like prior to the seizure. So sometimes that may be something they sense before the seizure, and then you may get the typical seizure afterwards. So so I see more often in those kids. In our other kids that, for example, they are quote unquote developmentally normal or neurologically normal, I don't see the anxiety stuff as a precursor to the seizures as much. After a seizure or sometimes several seizures, it definitely can have more behavior, mood issues, and labile issues with anxiety. That's not uncommon after a prolonged seizure, or if they've been having lots of seizures. Sometimes I see it after the seizure itself.
So are people who have migraines more likely to develop seizures?
Not necessarily. So there is something that we term in neurology called microlepsies, where many of our folks and I see more in a teenage and adult population. I don't see it often in our kid population, but partly that may be because sometimes they don't get diagnosed with migraines, or they really don't relate to migraine symptoms, so they don't really get diagnosed with migraines. But it's not uncommon for many of our folks that have epilepsy also have migraines as well. So we're not really sure whether it's the chicken or the egg phenomena, or they're related to some degree. Because sometimes some of the migraines, you get these auras that sound like auras of a seizure, and so it's not uncommon per se. But I wouldn't necessarily they're particularly mutually inclusive of each other.
Okay, thank you.
Were there any
Okay.
cases or anyone that had a case they want to bring up, or?
I have a case of sorts if no one else has anything they want to present.
Yeah, let's maybe see if there's any more questions. Want to make sure we optimize the time here though and see if there is a case. So Lynn asks, can childhood head trauma also be possible etiology?
Yes, it definitely can. You know, so the concussions, that's something that times are changing. So I'm from Florida, so we're in the South, so we're like a big football state. I went to a big football school at the University of Florida, so I appreciate that. But being a doctor neurologist, you know, for me the brain is important, and you only kind of get one brain. You don't get to fix it. It doesn't really heal itself like other parts of the body can. And so I've been not on a crusade, but I definitely try to encourage my families or kids of epilepsy just to avoid these kind of sports where you don't need to, like football and stuff like that. But ultimately, it's kind of their decision. But definitely not just football, but also, you know, car accidents, motor vehicle collisions. It definitely can be a setup for epilepsy down the road. Obviously, it depends on the degree of the injury. Was there a loss of consciousness? You know, was there like a fracture or hemorrhage? Did they have to be, you know, admitted to hospital? Many times, I would say that for the folks that have a higher risk for developing epilepsy, usually it requires some degree of injury where sometimes you should be able to pick up some degree of either damage or scar tissue or injury in the brain, then that may be set up for epilepsy down the road, sometimes years, decades down the road.
Great, thank you. Cindy asks, do we know the cause of why there is increased risk when a kid has febrile seizures? Is there damage that occurs as a focus?
Fibroblast seizures, kind of what I mentioned, it's multifactorial. The vast majority most likely is part genetic. So sometimes there's a family history of it, but sometimes you may be the first one to have them. But you know, also keep in mind that sometimes people may have had like fibroblast seizures when they're young, but they outgrew it. So they never saw a medical provider, and it was 20, 30, 40 years down the road, and they've long forgotten about it. So if you really delve, a lot of times there is a family history of it, but invariably it ends up being a genetic factor. But obviously there's some environmental triggers as well for some folks. Damage, there's no really good documented case, even for any type of seizure, whether it's a febrile seizure or just a febrile seizure, an epilepsy, for example. So, because a lot of times folks get concerned, they ask me, well, you know, is there brain damage because my child had a seizure? Typically, if it's limited, self-resolved, and I say limited in the sense of less than 5 minutes, less than 10, 15 minutes, which realistically, if you see a child having a seizure for 5, 10, 15 minutes, it's a long, long time. There's no good evidence of cell injury or cell death. They've done studies on rat, mice, and chimps in the laboratory where they're provoking seizures, and they're saying, well, at what point do you cause neuronal cell death? Well, it's hard to translate that into human tissue, but I would tell you that I've had some kids that were in the ICU that had encephalitis, and they were seizing constantly for hours. And they were on, obviously in the ICU, we had them on seizure medications to try to control the seizures. And some of these kids did okay, not normal, but they weren't quite normal afterwards. And there's some kids that were much more delayed. So I would say is if this, just as a general for most families, I tell them, if the seizure is less than 10, 15 minutes, I think the risk of any brain injury long-term, otherwise if the kid kind of comes out of it and they're back to themselves, is very, very significantly low.
Excellent, great questions, everyone. Thank you. Any other questions, Dr. Dalton?
Yeah, case question-ish, sort of. So 10-year-old female who I think family said had maybe 2 or 3 episodes of seizures, like 3 or 4 years prior, hasn't needed medicines. I got to see this child last month because she had her first episode of hallucinations, visual and auditory hallucinations.
Okay.
She has a history of DeGeorge syndrome. So, you know, this is all fun for a guy out in the frontier, Nevada.
Yeah. So obviously the DeGeorge syndrome, you and I can all Google, they do have a high risk for seizure as well. So I would definitely send them. So they never saw a neurologist.
So they might have years ago, but
Okay.
haven't recently. You know,
Okay.
we don't have EEG, so I can add that to the plan. Did lab workup and she was hyperthyroid. So,
Okay.
So sending her to an endocrinologist. So, you know, I'm probably not going to see him much from here, but
No, that's good stuff. Especially, yeah, for anyone that has a history of remote febrile or seizures or whatever, if they had it work or didn't work, and you're seeing this kind of new spells, it doesn't hurt to, if you're suspicious of low seizure, you can just order routine EEG, see what
Okay.
that shows. Or if they have obviously clinic and what spells, then send to a neurologist and we'll kind of work them up again. Because sometimes these things do come back. A lot of times it probably isn't something else, like you said with this kid. Maybe it's a thyroid issue that's causing some of our recent hallucinations, but if there's ever a remote history of seizures, whatever the type it is, and they're having these new spells make you suspicious, it doesn't hurt. I think you're just doing your due diligence at that point.
okay.
Thanks, Dr. Dalton. Any other questions from the group?
I think Catherine was asking about autism and seizures. Anything to know besides what's already been discussed about children with developmental delays? That's such a big topic. To be honest, it's not enough. I mean, you need like hours to go with it because there's so many reasons for autism. So sometimes it's something that you're born with, as far as, you know, was it like a difficult delivery? Did you have like an octave brain injury? And sometimes many of autistic kids had no delivery, had no delivery. There wasn't like a traumatic birth, but then obviously they have autism that developed over time, and sometimes with seizures. And these kids are probably, obviously the vast majority are part something genetic, whether it's something that's inherited from the families or it's just an odd mutation. This is just the way God made them.
All right, thanks, Catherine. Anything else we can address here today?
Yeah, so I'll pose this case. So Colin, a couple times a year, I would say, we might see a child around, you know, between 12 and 24 months old or so, who comes in with kind of some kind of symptoms like URI, maybe low-grade fevers, but a very prolonged episode of sleep. And then the blood sugar comes back at 200, let's say. So some ketones there. So we're all thinking ketotic hypoglycemia. The child is sick, so spent a long time sleeping, maybe had a low blood sugar and then bounced back up. But the question in my mind always becomes, did that child have a seizure? Is that
Right.
A, why they slept so long? Is that B, why the blood sugar then rose so high? And of course, I'm saying that we rule out diabetes in those kids. What's your experience on that? And what, in a case like that, if we hypothesize that the kid had a seizure, if we then did an EEG, what's the likelihood of finding anything on that?
The routine EEGs are, it's like I said, it's a spot test. So it can kind of tell you what happens right then and there. It won't necessarily tell you what happened before, what will happen in the future, but sometimes it can. So obviously if there's some abnormalities in there, that makes us a little suspicious. Oh, maybe the child may have had a seizure or something, or maybe they have a lower seizure threshold and it requires further work. But I think in that particular case, I think a routine EEG is probably reasonable. And as with things in general, you kind of have to wait to see if there's a pattern that develops. So if you see more episodes, that makes you more suspicious, and then say, okay, well, maybe we need to do like a longer video EEG, have them see neurologist, do more of a workup. But I think just a routine EEG, that's normal, and your suspicion is more of an endocrinologic, continue that workup. But obviously, if the spells persist and the endocrine side is perfectly normal, then I think send them to us and have a second look at it.
All right, thanks.
All right, question here from Elsa. Are drug-exposed babies at higher risk for seizures or any other neurological issues?
Bottom line, yes. That's kind of the short answer. It's obviously it's a little more complicated than that. Obviously, is what drugs were they exposed to? How early on were they exposed to them? To what degree? What amounts? Obviously, the biggest factor I usually would suggest is like how do the kids do in the neonatal period? Because that's a really good indicator of how they're going to do. I think long term. Whether it's like whether did they have like NAS where they have to be on morphine or it's kind of on a wean. There's certain drugs that sometimes that makes it a little high risk for seizure and developmental issues. So these are obviously if clearly alcohol, fetal alcohol syndrome, if they were on amphetamines, those tend to cause more issues I see as far as in the seizure standpoint. Yeah, so it just depends on how long they were on it. And you may see varying degrees, sometimes very mild, and these kids have some issues, maybe behavior, mood issues early on, but in a good environment, a good family, good support system, and good therapy, they actually do pretty well, and they're almost normal-like, if not normal. And then you have some kids that are, have very significant difficulties, and they have more issues down the road.
Hi, Mordecai here. Dr. Nguyen, I noted on your last slide, the last epileptic syndrome that you mentioned, you had a list of 3 drugs that exacerbated that syndrome. I was wondering if you give a little insight onto why that happens.
Yeah, so that's something something I leave more for because our medical students rotate to neurology, so that's why I've kind of condensed a little bit. So that's kind of more geared towards my medical students. So as far as seizure medications, most of you will not start kids on seizure medication. You'll kind of continue if they're on it from somewhere else, but sometimes our ER doctors, for example, sometimes if they see a kid with having seizures, maybe they see them for the 5th, 6th time, and the kids don't have insurance, or they don't have healthcare, and they or the neurology appointment is 3-4 months away, and so they're trying to figure out, well, this child obviously has epilepsy because they've had more than 1 seizure. We've done the initial workup in the emergency room. We've done the blood work, the CAT scan, things normal. They've been here back multiple times. We need to put this kid on something until they can get insurance or they can see a neurologist, because that's who they need to see long-term care. So you're trying to figure as a primary care doctor, well, what can I put this kid on seizure-wise? And so nowadays, you try and pick up so for example, if a kid has seizures and you determine, okay, I need to put this kid on some kind of medication. You want to pick something that they can afford, first of all. Most medications are generic now. You want to pick something that is easy to afford. And if they're traveling from somewhere, whenever they get back, for some of my kids I see, sometimes they're from Mexico, they're from Latin America, Europe, or whatever. I want to make sure it's available. Nowadays, most of the medications that are available in the US are available overseas. Keppra, for example, I would say is, 4 or 5 years ago, it wasn't on generic. So it was expensive if you don't have insurance. And so phenytoin Dilan is pretty widely used around the world. We don't use it as often here, maybe in the US, but we still use it in our older folks. And we use it very widely in kids and adults across the world. So phenytoin, for example, is a medication that many ERs or first-time doctors will put someone with seizure on phenytoin. Probably good. The problem is sometimes certain medications work for certain seizure types, and certain medications don't work so well for certain seizure types. So in that particular slide, we were talking about a generalized epilepsy. And so generalized epilepsy usually work better with certain types of medications. So like valproic acid, ethosuximide, lamictal Keppra works usually pretty good. Phenytoin, for example, is usually used more for focal seizure medication. So if you give someone that has potentially a generalized seizure, whether it's generalized myoclonic epilepsy, juvenile myoclonic epilepsy, childhood Absence epilepsy, if you give phenytoin Dilantin or oxcarbazepine trileptal or carbamazepine tegretol, so these are sodium channel blockers, focal acting medications, you will make the seizures worse. And so that's kind of the point behind that slide. That little at the bottom.
Thank you, sir.
All right, we just hit the top of the hour. Any last thoughts, Dr. Nguyen?
Nope. Hopefully this will be helpful. Like I said, this just to kind of see what's available. And so we're here for you. And then obviously, if you always have a question about something, just kind of run it by us. We're certainly able to kind of give you some help and some curbside if you need to, get something in the office. And that's kind of what we're here to provide service for you guys. And hopefully it's a little more informational, give you some background, and feel more comfortable to kind of, and don't be scared necessarily of it. It's more scary really for the parents than it is for the kids. And I usually tell most parents the kids will be fine, and we're just here to kind of give information and kind of reassure that the ways to treat and manage things are very, very manageable for the most part.
Excellent. All right, there is one question from Jed that just came in that I want to address, and then we'll wrap today. So for an adult who had several seizures at 3 years old and now takes oxcarbazepine, what is your opinion?
That's probably, I mean, it's not, if they had several seizures when they were 3, I'm suspecting maybe they might have had febrile seizures. And if they're on oxcarbazepine, I suspect they're probably having a focal seizure. I don't know who they're seeing or neurology, what imaging studies they've had done, but that's a perfectly reasonable medication. But obviously, everyone's different. If it's not working for you or the side effects, then you need to talk to your doctor and neurologist about, do you want to try something else? Or if it's been a while since you last saw a neurologist, you probably should go back and see him to do kind of a checkup.
All right.
If a patient were to come to me and be like, well, doc, I don't think I need this medicine anymore. I mean, I probably should send them to neuro, but what should I tell them?
And that's the thing, that we get that all the time. So the question is, why do you feel like you don't need it anymore? So it's my adult, when I first came here, I think we don't have, we know Northern Nevada is good with many things, but I think the neurology side of it has been kind of lacking, not just on the pediatric side, but the adult side as well. So sometimes we've had folks that come in that have, they're in bazillion medication, they didn't need to be on so many medications. By you telling them why are you at the point where you feel like you don't need the medication? Is it a side effect? You don't like taking the medication? What's the issue? And for my teenager, I tell them also it's a driving issue, because if you have a seizure, you can't drive for 3 months. That's here, but then some states it can be 6 months or a year. And obviously, if you have a seizure, you can die. And so I also talk about SUDEP, SUDEP, sudden unexplained death in epilepsy patients. So that usually will bring in my parents for those that kind of inconsistent or non-compliant about when I'm talking about the risk factors for SUDEP and stuff like that. And then for my teenagers, my carrot is usually driving. So usually I bring them in with the driving thing.
All right, well, really great session today. Thank you, Dr. Nguyen. Fantastic information that you shared with us here. And just really great questions from the group. Really appreciate the discussion. So thank you all.